If you could just remind Nicole to announce herself when she's in. Good morning and welcome back to the second day of the board's October 27, 28, 2021 board meeting. My name is Song Oh, President of the Board. As I mentioned yesterday, the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. Also, as mentioned yesterday, the meeting is being conducted consistent with the provisions of Government Code Section 11133. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting. Information and instructions are posted on our website. As indicated on the agenda, following the petition hearings today, the board will convene in closed session after deliberating on all the open session items except adjournment. Due to technological limitations, adjournment will not be broadcast. Adjournment will immediately follow closed session and there will be no other items of business discussed. As with our meeting yesterday, I will again announce when we are accepting public comment. I have advised the meeting moderator to allot 2 minutes to each individual providing comments on a particular agenda item. This is important to ensure that the board has time to consider comments on the agenda and complete its business. Before we get started, I would like to ask staff moderating the meeting to provide general instructions. Moderator?
Thank you, Mr. Board President. I would like to remind board members and senior staff who are not speaking to mute their microphones during the meeting. If I detect background noise during the meeting as a result of unmuted microphones, I will interject with a brief friendly reminder or simply mute the microphone. To facilitate public comment, we will be utilizing the WebEx question and answers feature, also referred to as the Q&A panel. When the board president reaches a point in the agenda at which public comment is appropriate, public comment will be requested. At the board's direction, I will turn on and announce the opening of the Q&A feature. Please note that the Q&A feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. Once given permission to unmute, the member of the public may unmute themselves and verbally state their comment. The Q&A feature is not to be used for typing out questions or for board members to communicate with one another. If attendees utilize a profane name, they will not be called upon to prevent members of the public from being subjected to profane language. While you are free to express criticism or negative views, for the sake of members of the public participating on the call, please do not use profane language when making public comments to the board. And with that, I return the floor back to you, Mr. Board President.
Thank you, Trisha. Okay, members, I will now take a roll call. And before, I just think Nicole is here, so we'll call to establish a quorum. Starting with Maria.
Here, thank you.
Hi, Maria. Thank you. Jake Patel.
I'm here, thank you.
Hi, thank you, Jake. Cheryl is not here today. Jose is not here today. Shirley Kim.
Here, good morning.
Thank you, Shirley. Ricardo Sanchez.
Here.
Thank you. Good morning, Ricardo. Nicole Tebow.
Here.
Good morning, Nicole. Debbie Veal.
Here.
Thank you, Debbie. Good morning, Jason Wise.
Good morning, Mr. President, board members, and public.
Thank you, Jason. Good morning. And I am here. All right. So the quorum has been established. So we're moving on to agenda item 14, presentation by Dr. Stephen Chen, Associate Dean for Clinical Affairs, University of California, Right to Meds Collaborative. Members, I'm pleased to welcome Dr. Steve Chen to provide the board with an educational presentation on the California Right to Meds Collaborative. Dr. Chen, the floor is yours, and thank you again so much for joining.
Thank you, President O. I'm going to share screen. And just let me first say, I want to thank the board for your service. I think it's so critically important, obviously. It's also been my career, patient safety, so it's my passion, and I hope that shows in the work that I'm about to share with you today. I want to thank you for this opportunity to share our work, the California Right Meds Collaborative. So just for a quick background, so you know who I am and the context I come from. I'm a Trojan. President O, I thought you were about to say University of California, Los Angeles. I went to USC, just to be clear. Graduated there, did a residency in primary care, worked for the VA for about 10 years, then joined USC, and became a faculty in residence at Cedars-Sinai Medical Center. And about 5 or 6 years into that, I called my department chair to take a look at working on Skid Row for patients who are homeless for about 10 years. And the gentleman on the right that you see in this picture is Dr. Paul Gregerson, a national expert in homeless healthcare. And he really taught me how to work with patients who are underserved in ways that I could never imagine. And that became the best part of my career. So I worked with homeless patients, uninsured and Medi-Cal for the rest of my patient care career. And just to round it, I have a couple of kids, both at USC, on the left and right there. Just again, to share more about the perspective I'm going to present to you today, I can just get a couple of quick patient cases, the kinds of patients that I have had the privilege of working with. I had a patient what was referred to me from an endocrinologist who had uncontrolled diabetes. No matter what he did with his insulin, the patient's blood sugar would come down, and he was just very confused. I met with him. Couldn't find any particular reason why he shouldn't have improved his blood sugar control. He seemed to be doing everything right. So I paid him a home visit. I got his address, went to his location down in Watts. I found the address, couldn't see a house. So I went to the gas station next door and asked the attendant, can you tell me where this address is? And he goes, who are you looking for? So I gave him the name. He said, yeah, come on over here. So he takes me to that location where there should have been a house, which was basically an empty lot, pulled open a board, and there was my patient living in an empty camper shell. So I did my evaluation of him on site, and I said, hey, we give you extra insulin for you to reach for. When we tell you to keep it in the refrigerator, where is it? And he sits in the refrigerator. So I took a look at where he was pointing, and this is not the actual refrigerator, but in the middle of this lot in August heat, there was this refrigerator with no door, and there was an insulin bottle sitting inside. So basically, he was denaturing his insulin every day, and by the time he got to use it, it was ineffective. The other case I'll share with you is had a patient with heart failure, just recently hospitalized, wasn't coming back to clinic, just wasn't coming back, refused to come back, and no one can quite understand why. So I paid a home visit to her. I knocked on her door, and it took about 5 minutes. I was about to walk away, and she finally opens it. She's huffing and puffing, and she'd walked about 10 feet to open the door. So I did a quick assessment, and what you're seeing there is what it's called pitting edema. She was carrying about 25 pounds of water in her legs, just heavily fluid overloaded. So I was able to make an adjustment in diuretic dose, check back with her. She urinated like she never had before, so she said, and was able to breathe. And our goal was then to continue to work with her medications and get her on the right drugs to prevent that from happening again. So just an idea of the kind of work that we do in primary care pharmacy. So what I'm going to share with you is this remaining unmet needs in healthcare that comprehensive medication management fulfills, the evidence broadly, as well as what we have generated, which I hope you'll be excited about, and then the California Right Meds Collaborative, which is aligned with many state initiatives. So I know I was preaching to the choir a little bit, but just to level set, particularly anybody in the public that's participating in this, U.S. spends about twice as much as the rest of the world on average in healthcare costs, by far number one in the world in that regard. And if you look at healthcare quality scores by many different domains, we do quite poorly. And if you aggregate all these numbers, we end up last place in healthcare quality of all developed countries. So pay the most, get the least. And a big reason why is 90% of chronic diseases require optimal use of medications to get to treatment goal. But we don't do well there either, right? You've probably heard some of these numbers. Over $500 billion left on the table every year because we don't get medications right. And that's not just drug interactions that cause harm to patients. That's when you choose the wrong drug, when there are other ones that are better and more effective. That's when you don't dose correctly. That's when you don't treat indications that need medications. It happens alarmingly more than most people think. Most hospital readmissions, which are obviously very expensive, are driven by misuse of medications or some kind of prescribing problem. And all in all, this comes out to being the fourth or third leading cause of death in the U.S. when we don't get medications right. And I'll give you one simple example. This is something that we should be ashamed of as a country that we struggle with. Half of all heart attacks and 3/4 of all strokes are caused by uncontrolled hypertension. And if you look at, you want to pick a condition which really points out the health inequities we have in this country. Death rates from hypertension in blacks are much more common than whites. And it results in high-profile deaths like these, where Black men at a very young age die from cardiovascular disease. Recently, this last summer, there was a paper that came out that looked at blood pressure control up to 2014 and then from 2015 to 2018. And what they found is over that period, comparing those two time ranges, the rates of blood pressure control dropped by 10 points. We went from 53% to 43%. And this isn't because the target dropped. The target was 140/90 that they use as a proxy that entire time. So in trying to figure out why, what would the explanation be? The authors thought, well, it's probably because of access to healthcare. It's probably why. But if you look at this graphic here on the left-hand lower pane, it's not access to care. Access to care didn't change during that time period. And what that lower left pane further shows is there was more obesity and more diabetes over that time period. Those are markers that you need more than one drug, 2 or 3 in many cases, to control hypertension. But what you're seeing here, that 4.2 bar, is monotherapy. Single drug therapy for hypertension actually increased during that time period. So the authors concluded that the biggest reason why we struggle with blood pressure control in this country is because of quality of care. We just need to get the right number of drugs on board to get these patients under control. So the authors concluded that this can be done. We can give more to the primary care docs to do. And I share this with primary care doctors, and they say, no, it doesn't work that way. Because if you look at the studies out there that look at how much time a primary care doctor needs to get their basic work done every day, it's at least 17 hours. I had a chance to speak to the past president of the AMA, who was a family practice doc. And I said, hey, I saw that study that shows that you guys work 17 hours a day or need to work 17 hours a day to get everything done. He said, yeah, we redid the data. It's actually 22 hours a day, even worse. So the point is we can't ask more from a system that just doesn't have any more to give, right? We need to better align the expertise of pharmacists in this area where we definitely have the expertise to do it, right? Because in the case of hypertension, you're talking about the first 5 lines of medications for blood pressure being generic, cheap, and widely available, right? We have no reason why we should be at 43% control in this country. So the solution I'm going to share with you through the collaborative is comprehensive medication management. And again, just to level set so we all have the same understanding of what it is, it's given the array of choices of medications for a given medical condition, choosing the right drug. And that's really important because it isn't enough to be in the right class of drug. Even in the same class of drugs, there can be significant differences between efficacy and safety of medications. It's really importantly getting the right dose, right? A great example of where we get the dose wrong often is depression. Right? Oftentimes in the primary care setting, a clinician will start an antidepressant at a starting dose and then never escalate it. And that does nothing, absolutely nothing. And it happens far too often. We've audited health systems and have shown that all too often nobody gets benefits from antidepressants in those, not nobody, a few people get benefits of the medications in those settings. There's safety of medications that we ensure by making sure drug disease and drug-drug interactions are managed and mitigated. We make sure that patients can use their medication devices safely and correctly. You might be surprised that what seem to be simple devices, once we train patients, they often forget about or get confused about even after a couple of months. So that needs to be revisited. And then, of course, most importantly, they can afford their medications they're getting. One thing I learned working on Skid Row is I could get a regimen for a patient with complex medical conditions as good in quality as my Beverly Hills patients that are affordable to them by knowing how to work with the system. So there's no excuse for not getting patients the right drugs, regardless of healthcare coverage. Sorry. One thing I should add is this isn't a one-time shot, right? With comprehensive medication management, this is evaluating the patient, making the changes necessary to get the patient to their treatment targets, and then very importantly, following up with that patient and working with him or her until they reach treatment goal. It's, again, not a one and done type of service. And I think this picture hopefully illustrates the kind of patient that we work with, right? This is a patient with multiple chronic diseases, had been seeing primary care and specialty, some of the best in LA County for a long time, and was just never getting to treatment goal. So a pharmacist got involved in her case, convinced her to bring in all her medications, and this is what she brought in. Almost 100 bottles of medications, half unopened, pretty much a disaster. And I guarantee you, only a pharmacist would like to see this. Nobody else wants to see this. So the obvious questions here, why didn't you take your medications? You told your physicians that you did, and she said, I was afraid of the side effects. So the next question is, why did you keep refilling your medications? And the answer was, I went to a pharmacy that was auto refill. So, technology doesn't fix everything. Medication fill records don't guarantee that patients are taking their medications. This patient took quite a while for us to work with, but in the end was able to get to all our treatment goals. So just so you know, I'm not speaking of purely personal experience. These publications from national organizations are not pharmacy-led. They're non-pharmacy organizations that endorse the importance of comprehensive medication management for patients. And what I will share with you from personal experience is work we did with Ultimate Health Services. We received an award from the Center for Medicare and Medicaid Innovation. It was the Healthcare Innovation Award. I'm sharing this with you because this becomes the foundation for the California Right Meds Collaborative. With this grant, we were able to integrate 10 clinical pharmacy teams into Ultimate Health Services, the team being a pharmacist, a clinical pharmacy technician, and a resident. We also had one video telehealth team that saw patients remotely at locations that were too small in square footage or too small in patient volume to warrant a full-time team. And then we looked at quadruple aim outcomes: quality of care, cost, access, safety, satisfaction from patients and providers. And what we did was we tried to address the most challenging patients, the most expensive, which is really where comprehensive medication management stands out in terms of its value. So we went after those patients that were frequently in the hospital, recently in the hospital. We developed an algorithm of 48 different triggers or queries infused in the medical record. This would look at medications, problem lists, demographics, vital signs, tests, and when combined, they would suggest gaps in medication-related quality or safety. Our teams would get these lists every month, vet them with the medical record, and if there was indeed a gap, UltiMed gave us the ability to self-enroll patients and inform primary care providers. And the interesting thing is we got zero pushback. Physicians were glad to have the help with these patients. And what we found was after about a month and a half of using these data sources for patients, physicians got it, right? That's what we were hoping. Physicians understood that this is something that helps my patients, that helps me, gives me more access to patients because now I can take these time-consuming, challenging patients and give it to somebody that can manage the medications, get the patient to goal. And so after about a month and a half, most of our referrals came directly from the physicians, and they were all high-risk patients. We provided comprehensive medication management. We kept going until the patient reached treatment goal. And just so you know, that's about 8 to 9 months, almost 10 visits on average per patient, but it's a huge bell-shaped curve. Some needed longer, some a little bit shorter. And even when patients reached goal, we kept the leash very short, right? We had our technicians do check-ins every couple of months. And just to be clear, they completed a yes-no checklist that they would administer to patients. So they didn't have to interpret anything. They just had to go through a yes-no checklist. And if any answers came out in the wrong column, the pharmacist would follow up with the patient and determine whether or not the patient had to be reimbursed. And we did this because up until this point, I've been practicing for 20 years. And what I'd see is I get very complex chronic disease patients. I'd get them to goal. I'd say, hey, good luck. Go back to your physician. You're great now. And then I'd see them 6 months to a year later, right? Because they fell back off. So it was important for us to do this to maintain their control. And we indeed were able to do that. So we enrolled about 6,000 patients, mostly Latino, a few more females than males, lots of uncontrolled hypertension and diabetes. And we used a very rigorous analysis model to evaluate outcomes. This wasn't a pre-post test. We used a propensity score match comparison, meaning we matched up patients who got the intervention, the pharmacist versus not, at different locations, and we matched them according to about 70 different variables. So pretty good apples to apples comparison. And we got results like this, right? Blood pressure was significantly improved. We got almost 90% under control within 45 days. And there are other results, but I don't have time to share with you, but we generally did an absolute difference of 10% or so better on every single disease state that we measured. Readmissions were reduced for patients that had previous readmissions to the hospital. It was 16% overall, but 33% for those that had a readmission related to medications. Mortality was different between the two groups, which we were surprised at, but that was statistically significant, even though the numbers were small. And this is one I wanted to share with you because I think it's really important. We tracked the drug-related problems that the pharmacist identified and resolved. and they came out to 67,000 for just under 6,000 patients. That's 11 and a half medication-related problems per patient. That's got to be frightening, and I can tell you that's not uncommon. I've tracked this data at Cedars-Sinai. I tracked it in the VA. It's generally in the neighborhood of 8 to 12 per patient, right, for these high-risk patients. And the other thing that might surprise you is the biggest problem we found was not non-adherence. Everyone thinks non-adherence and polypharmacy, those are the biggest problems in healthcare when it comes to medications. They aren't. And in fact, in the VA at Cedars, it was the same thing. The biggest problem we find when we evaluate for drug-related problems is the appropriateness and effectiveness of drug therapy. And what I mean by that is wrong drug, wrong dose, and indications for which there is no treatment being given where there should be a treatment being given. And you can see that's the red slice of the pie here, a third of all interventions, right? No doubt there were patient safety issues, right? We caught side effects. We got patients that were at risk for side effects because of drug interactions, things like that. That was 20%. Yes, there was non-adherence. Yes, there were patients that were doing all the wrong things, or eating or drinking the wrong things. But by far, the biggest problem we run into are prescribing issues. So physicians, just quick summary, is using standardized surveys. They're extremely happy with their service, so much so that physicians from the control sites tried to send patients to the treatment sites, which would have ruined the study. We were able to stop that. Patients loved it. There were letters coming into Ultimate unsolicited talking about how great the service was. Ultimate was very surprised, but very pleased with that. And in the end of the day, all the things that really mattered to patients were being met. The quality of care, satisfaction, they were getting healthier. So we took learnings from this project and we decided, how can we make this available to more patients, right? This is so important for them. To quote some of my pharmacists working in the project, they said it was shocking to see that some of these patients were even alive with how brittle their chronic disease control was when they started. So we figured, well, let's go to the health plans and see if we can work with some of these managed Medi-Cal plans and help them with their patients. So we shared what you just saw, a little bigger slide deck of all the results with a couple of them. And we said, is this something that you can benefit from? And they said, yeah, this is really important. However, we're not Ultimate. We're not Kaiser, right? We are all over the place. How do we get this program available? How do we make it available to patients where they live? And this is not an uncommon issue, right? When I was on Skid Row working, these were quite common conversations that I'd hear in the clinic. The one on the left, physicians complaining that we schedule this guy to come back, he never comes back. What are we going to do, right? I think what some people don't realize is that homeless patients have very busy lives because they deal with things that you and I don't deal with. Right? It's a very different set of circumstances. The other, on the right-hand side, is patients would get all sorts of instructions on what they have to do. And then I'd see them later and they'd say, "This is, I'm not doing half of these things. I can't, right? It doesn't work for me." So, whether you want to call it, cultural alignment or just, care that's appropriate given the patient's limitations, that was also a mismatch as well. So we said, look, let's make this work through community pharmacies, right? They're in neighborhoods, they're trusted, easily accessible. They have staff that are culturally and linguistically aligned. It just makes sense, right? And we can do this because we can take the lessons that we learned from our big project, our 30 years of experience with comprehensive medication management, and not only train pharmacists, but monitor and ensure that the outcomes that the patients need, the plans need are being met. So California Right Meds Collaborative was born with this goal of creating this network. And I think you're well familiar with how many pharmacies there are in the US. More than 4 times as many pharmacies in Starbucks is probably the way I like to phrase it to make it really simple for most people. Most patients live within miles of a pharmacy. And if you look at some studies that have been published recently, non-Medicaid seniors show up in pharmacies 2 to 3 times a month. It's a lot of face time, a lot of opportunity to work with their pharmacist on med management issues. So our collaborative, I'm sorry about this messy slide, is all heavy about training. We train them to death, and it needs to be that way, right? Because this is new for many of the community pharmacists that are doing this work. We adopted the Institute for Healthcare Improvement's Breakthrough Series collaborative process for training. These are our 4 health plans. Blue Shield hasn't started yet. They're starting in January. But as you can see, we have 2 Medicaid managed care plans and 2 commercial plans that are involved so far. What you're seeing here, LS, are learning sessions. These are full-day training sessions. We have experts coming in talking about how they've managed their comprehensive medication management programs, what they've accomplished, how they've accomplished it, what are their tools and resources. And then we have breakout sessions that are of different levels for new teams, intermediate teams, and advanced teams to advance their level of care. And in between these learning sessions, we have all sorts of other trainings. We have live webinars. We taught them how to do virtual care during the pandemic. We taught them how to manage social determinants. And very importantly, we have a very rigorous continuous quality improvement process. We track process measures, timing measures to make sure our teams are if safely and efficiently getting patients to their treatment goals. So other key components that make this work, we vet pharmacies very carefully, right? So if a pharmacy would like to participate, they complete a survey. If the survey passes, they get an on-site assessment. The health plan looks at where they're located, looks at some quality data, and if those 4 boxes are checked, they can join the collaborative. We were fortunate to partner with LA County on a CDC grant that funds some of this work in LA County, just administrative, not paying for the services. We have a data platform company that's helping us to aggregate data for us to make this a lot more efficient. This is where the pharmacists document their care, their interventions, and we're helping them develop a continuous quality improvement platform within it to make sure that the whole process provides a dashboard and is very efficient in helping pharmacies perform at their maximum level. As I said before, because of our work with that CMMI grant with Ultimed, we were able to share a best practice model for delivering telehealth. And as you'll see in a minute, the results came from largely telehealth during the pandemic. And we use, I mentioned before, a very rigorous CQI process. Part of it was learned from the late Dr. Ron Victor, who ran the Black Barbershop program for hypertension, where pharmacists were sent to barbershops to manage high blood pressure. In his program, he achieved 90% control of blood pressure in a very challenging population versus 32% usual care. And his methods, his very aggressive CQI methods, I learned from him and adopted for our collaborative. We also ran a asthma program with Blue Cross Insuring about 15 years ago, where Blue Cross hotspotted Medicaid patients that were heavily used in the emergency room hospital due to asthma. And we were able to engage pharmacists that were local to these areas to be trained by us, a very rigorous training session, similar to what I'm describing here. And if they passed the training session and the evaluation, Blue Cross would pay them for asthma visits. And as you can see, in the first several hundred patients that came through, we saw 70+% reductions in costs and acute care utilizations for those patients. So those are lessons learned that we are infusing into this collaborative. And probably most importantly is the health plans have agreed to pay a value-based payment. So that payment is a mix of fee-for-service, modest, not too much, and then more importantly, if and when the patient gets to treatment goal, they get the full amount of the payment. Right? So this is very much a win for everybody. Health plans don't pay excessively for just hoping that care will be good. Pharmacies have to perform to get paid, and patients in the end are driven towards better results, better healthcare. So the pilot I'll share with you is from LA Care. But these are our participating pharmacies in the middle, and on the right, you're seeing the federally qualified health centers that were paired with these pharmacies. This is important because if you have, let's say, 100 patients enrolled in your pharmacy getting comprehensive medication management and 50 different physicians, good luck trying to create a relationship with 50 physicians, right? So we were very conscientious about identifying federally qualified health centers that were struggling with quality scores, and we offered the service to them as it didn't cost them a dime because the health plan was paying for it, and it helped with their pay for performance measures. So again, a win-win for everybody. Now, when Ultimate set out to do this, when LA Care set out to do this, they picked uncontrolled diabetes as their initial population of focus. Their metrics for diabetes were not great. So we enrolled people with an A1C, a 3-month measure of blood sugar control, above 9%, which is quite out of control. And as you'll see in a minute, the average A1C was over 11 for enrollment. We set up the payment model as you see here in the middle. In order to get paid fully, to get that bonus payment, the A1C number had to be less than 8%, and sometimes less than 7, but definitely less than 8. Blood pressure at least less than 140/90, in many cases less than 130/80, as current national standards dictate. And they should be on a statin if they aren't already on one. Almost every diabetes patient needs to be on a statin to reduce cardiovascular disease risk. Now, I need to frame some of this because LA Care asked us for this analysis after only about 5 months. And if any of you have worked with diabetes patients, that's not enough time, right? It takes 9 months or so to get your typical diabetes patient under control. But they wanted to take a look and see where we were headed at that time. On top of that, as I mentioned, we launched right after Thanksgiving as the pandemic was just taking off. Clinician doors were shut, and it was very difficult to contact physicians. So it couldn't have been worse circumstances to pilot this program. This is what we started with in our pilot. A few hundred patients, a couple hundred, lots of underserved areas, lots of minorities, and average age of 53, a few more females than males. And what you'll see here are results, as I said, about 5 months in. We were hitting A1C drops of 2.6, which is, if you don't know, a huge number. Most studies that evaluate interventions are really happy when they get 1 to 2% reduction. We're not even done yet at 5 months. We're hitting 2.6. So really a testament to the hard work that our pharmacists were providing. The other impact was uncontrolled blood pressure. We were dropping systolic blood pressure by 23 points and starting to approach mid 80, 90% control of hypertension. Again, really phenomenal numbers given the limited time period that we were looking at for these patients. And you might be disappointed to know that at baseline, statin utilization was 42%. Again, almost every patient with diabetes should be on a statin, so we doubled that to 84%. So all in all, these results were enough for LA Care to say, this is no longer a pilot. We're now going to adopt this as a program that we support and scale up. So really excited about that moving forward. Again, kind of to wrap this discussion up a little bit here, we have a program that's sustainable, that's value-based, that partners pharmacies with physicians and medical groups to provide comprehensive medication management and leverage the fact that these pharmacies are widely available, they're accessible, they're trusted experts in the community. Almost always, if the pharmacist isn't culturally, linguistically aligned with the population served, the tech or the clerk is, and that makes a big difference. That relationship they help build makes a huge difference. I showed with you results from both our CMMI grant and our pilot, showing that the results that we're achieving are indeed quadruply aligned, cost, quality, and satisfaction for both providers and patients. So what's next? We are in the process of increasing the number of pharmacies participating, enrolling more patients. Our goal is to get enough patients to each pharmacy so they can hire a full-time pharmacist to support these services. And that way they're not splitting time between dispensing and clinical duties. We launched a parallel collaborative called Psychiatry for Population Health Pharmacists. And this is because, as you might guess, when you're talking about these high-risk patients that need this help, many of these patients have underlying mental illness. And if you're not addressing that, you're probably not going to get control of the chronic diseases they have, the other chronic diseases. So we have experts in psychiatric pharmacy teaching our teams how to manage basic, relatively mild, moderate behavioral health conditions. And even just as importantly, understand when you have a patient who needs more help, how to connect them to care, how to close that loop. We have other health plan partners, 5 more that we've been connected to across the state. This is thanks to our partnership with the Right Care Initiative and California Department of Public Health. Covered California, we were connected to by the California Chronic Care Coalition, and we're working with CPHA to basically make comprehensive medication management a benefit to their participants in 2023 when their benefit refresh happens. So great partnerships with both these organizations in helping to lead that effort. We just completed a response to Covered California addressing their strategic plans and how they align with comprehensive medication management. We also met with leadership for Covered California, shared a similar presentation to what you saw, and they're very excited about the alignment between our work and their goals. And then to kind of call on CPHA again, thanks to CPHA, we were able to give some input into Medi-Cal's medication therapy management service benefit that just came out. This is currently fee for service, and it's kind of mislabeled because it's actually comprehensive medication management. So it may not be perfect yet, but it's what a great start to know that DHCS is interested in funding this kind of work and helping improve the health and safety of our Medi-Cal patients. So I didn't take much of a breath. I'm sorry. That was 30 minutes of a lot of information. Would love to take any questions at this point.
Dr. Chen, thank you so much. That is so impressive. And, we are always very happy to have folks present in these exciting studies. So I would like to, I have some questions myself, but I'm gonna allow our members to ask you questions first. So I'll probably just open it up. If anyone would like to ask Dr. Chen any questions, go ahead.
Hi, Song. This is Debbie Veal. And first off, I want to say that I attended, I think, three of the three training sessions that you had listed there, Steve. I think I was at all three of them. And I have to say that they were very well done and provided, I think a great baseline for the individuals that were there along with myself. So I can kind of vouch for the process, I guess is what I could say. And I think this is super exciting. And I think, some of the things that the board's trying to do in order to free up the pharmacists and provide them, with the collaborative practice abilities and things like that only feeds into your program. So it just kind of shows how important it is to try to, enable the pharmacists to really practice at the top of their profession instead of middle bottom. So Dr. Chen, Steve, thank you very much.
Dr. Veal, thank you. Thanks for attending all our sessions. Really appreciate that.
Thank you, Debbie. Anyone else with any questions for comments for Dr. Chen?
Hi. Hi, Dr. Chen. This is Nicole. I had heard about this program several times. Dr. Tam Fan is our clinical pharmacist at the Los Angeles LGBT Center. I had actually heard about it, though, from some fellow FQHCs that had hoped to take part in the program, but were not able to. I believe that was during the pilot phase. I know you're adding new pharmacies, but are people just able to enroll if they want to? Is it a vetting process? How does one become a part of this program?
Thanks, Nicole. Thanks. And yeah, Tam is fantastic, by the way. So are you referring to how FQs join or how pharmacies join, or both?
A little bit of both. I just want to be able to share this information.
Okay. Yeah. So we have a website, CRMC, or email, crmc@usc.edu. It is on our website, calrightmeds.org. Anyone who wants to join can connect with us, and we can share with them a survey online that they can complete. This is for pharmacies, by the way. And once that survey is completed, it gets shared with LA Care in this case, or it could be any health plan that's affiliated with us. They would then vet the results with us, conduct an on-site survey, and if all looks good, they can participate in the collaborative. So on the pharmacy side, there's a little bit of vetting that takes place. For the FQ side, what the plans have been doing is looking at the report cards they have for the FQHCs, and if if the FQs, the ones that appear to be struggling, get invited to join, to participate and partner with one or more pharmacies. So that's usually how it's done. But I would say that if an FQHC is interested, they should just reach out directly to either our collaborative or to LA Care Pharmacy. I'm talking about LA only, but they can reach out to us and we can facilitate any connection to a plan that would make sense.
Great. Thank you so much.
Okay. Thank you.
Thank you, Nicole. And any other questions? May I ask a question? So Dr. Chen, this is super exciting, and I think that this is the future of pharmacy, obviously. And I think we've been saying this for many years, but it always is not easy to get to that point. And, my vision, hopefully one day, is to have these both pharmacies and clinics, but also have pharmacies performing with pharmacists providing these services. And obviously, what do you think, what will it take for us to have this everywhere? Like, what do you think, how can we make this happen? What will do you have anything that you think we could do as Board of Pharmacy? Is this health plan issue, or, where can we take this so that we can have this everywhere?
Well, this is what a great question, President O. That's the golden one. I think when we achieved provider status in California, as I like to put it, it put us on the team, but with no guarantee that we'd ever play in the game. And the issue is that even though we're now recognized as providers, there's no funding stream that says that you have to pay pharmacists for these services. And so it's easier for plans just to not think about it, right? I think the board has done a remarkable job in advancing legislation like AB 1533, which further improves the opportunities for pharmacists to get involved in this work. I believe that ultimately getting parity in provider status with other health professions will change the game, right? A good example of this is with Ultimate Health Services. Their administration was thrilled with the work that we were doing, and they committed to paying for the program after it ended. And then about a month before it ended, they came back and said, gee, we can't make the math work because we can't bill for pharmacists. So it ended up that they scrapped the program, sadly. Now they're building it back up today because they're looking back and saying, gee, we need to do this. But that's an example where there's just a misalignment of incentives in the health system that results in pharmacists being left off the table because they can't be billed for. However, having said that, I took the approach in the Cal Reitman's Collaborative of trying to work with the high value priorities of the payers, right? Whether that be cost savings or improving metrics that matter to them, whatever it might be. If you target comprehensive medication management to the highest risk patients, as hopefully as you saw, the evidence speaks for itself. It pays itself many times over. The return on investment financially has come in as high as 12 to 1. In fact, Inland Empire Health Plan, one of our partners, just did an analysis of one of their CMM programs, and they determined that the return to 1 was over 12 to 1. So I think we can work with the payers to integrate this in a way that's value-based, which is what we're trying to do now. But ultimately, having parity with other health professions in terms of provider status and payment opportunities is a game changer.
Perfect. Thank you, Dr. Chen. And that's mainly federal provider status we're talking about, right?
It is, although, there are some states, Texas and others, that have laws that prohibit, for lack of a better description, payment discrimination. So if there are qualified health professionals that can provide a certain service and you happen to be putting a pharmacist in to provide that service, payers cannot discriminate and say, we won't pay for pharmacists, but we'll pay for NPs or PAs or physicians or otherwise. So some states have been able to kind of work around the lack of federal provider status and find a way to make sure pharmacists are fairly compensated for their work.
Got it. Okay, perfect. Thank you, Dr. Chen. And anyone else with any other questions, please?
Dr. Chen, this is Jake Patel. Great presentation. I think you're making a great impact in the communities and taking the level of care to the next level. You spoke a little bit about Texas, and do you have any data, or do you know if you're practicing pharmacy in Texas, do you get paid for these services by certain healthcare providers because of the law they have?
It's a good question. It's one thing to have the law, it's another to get paid, right? So I've not checked into my colleagues in Texas lately. I just remember we had met and talked about their law coming into place. So I don't have that data now. It's a very good question because we see many examples of that where the law is there, but people aren't billing. Minnesota is a good example, right? Minnesota has had a MTM payment model similar to what Medi-Cal just passed. And when I spoke to Minnesota folks probably a month ago or so, they said, the integrated practices where pharmacists are in clinics, there is billing taking place, but it's almost non-existent in the community pharmacy side, which is, as we just pointed out, where it's badly needed.
Yeah, no, absolutely. There's so much talent out there and within the mile of every Californian, and they can take advantage of the services. And together we can collaborate and figure out a solution so that we can free up our pharmacists to provide this service. And the general public is going to tremendously be advantaged with that. So thank you for the presentation.
Fully agree. No, thank you for the question. Fully agree. And just look at our pandemic, right? The hero role that community pharmacies played. And now that we're hopefully on the downhill side of the pandemic, we should be looking at how do we leverage our community pharmacies to be a backbone for public health for future catastrophes, right? We need to do that now rather than wait for the next one. So yeah, great comments.
Absolutely. Any
Hi,
other
Dr. Chen.
questions?
This is
President-
Jason Weiss. Oh,
Go ahead, Jason.
as a non-pharmacist board member, I really do appreciate your presentation and your work and your focus on the underserved communities, high-risk communities. Can you please tell me how large is the patient load for a pharmacist on comprehensive medication management? For that group, and I'd anticipate it would reduce when you move it out to the general public, correct?
Yeah, so great question. That's the question that a few people ask, but they should. If you're talking about the workload for comprehensive medication management for a pharmacist who's integrated in a medical clinic type setting, that's about 300 plus or minus, maybe 350, 350 plus or minus. That plus or minus depends on the complexity of the patient population, right? If you have, for example, a large number of heart failure patients, you're not going to be able to see that many because they need a lot of hand holding, a lot of time, right? As opposed to, say, a largely asthmatic type population where the visits are more limited and short term. So it's in that number when you're integrated. Now, to your point, when you move it out to the public, to a pharmacy, now you're kind of a data island, right? You're not necessarily integrated with the practice, and it's a little more difficult to be super efficient. So we estimate that a full load would be somewhere in the neighborhood of 200 and 250. Now we're trying to improve that gap through that data partner that I mentioned to you, Arene. They're able to aggregate data from FQHCs, from hospitals, from payers, from pharmacies to create essentially an EHR type platform where data can be shared between all the different parties. And that's kind of a game changer because if we can get that level of information sharing, that'll allow us to improve or increase the numbers that community pharmacies can see. But at the moment, based on the payment model we set up and the anticipated volume, we think that about 200, 250 patients at any given time will generate enough patient volume and payment to the pharmacy to bring in a full-time pharmacist dedicated to this.
Okay, great. Thank you again.
You're looking for Chen? Thank you. Thanks, Jason.
I think Anne also had a question for you, Dr. Chen.
Hi, Dr. Chen, thank you again for coming today. This was so informative. I have a quick question about the scalability of your training and onboarding program. Do you believe that there's sufficient scale there?
Yeah, great question. So each of the plans has a little different twist on how they want to select pharmacies. So for example, Blue Shield, I haven't spoken extensively with them, but we've worked with them for a while. They already have, for example, a pretty nice network of pharmacies that they work with currently. So I think for them, identifying pharmacies where we can do this with would be really easy. Other plans had no such network, so we had to work from scratch. So that part was, I'd say, a little bit challenging, but it's going to vary by the health plan. For the training part of it, I don't want to say thanks to COVID, but yeah, we found that we can train remotely very efficiently and very effectively. And we have a series of online modules on comprehensive medication management specific to California and our underserved and diverse needs that we have available that gets people level set before they get started. So the short answer is, yeah, I believe that we can scale this up across the state and even beyond. We just need more participating plans to do it.
Thank you, Dr. Chen. Are all those health plans like locally based, so like regional health plans? So would you need to work with like maybe other pharmacy schools in other parts of the state? Because we have a lot of pharmacy schools throughout the state.
Yes.
So
yes, we need to take advantage of that too. So we already are working with several pharmacy schools, and as we're spreading to other parts of the state, you're exactly right. UCSF is going to be a partner. Toro, others will be a partner. So we are definitely leveraging the pharmacy schools in this effort, and they're not all regional. So LA Care obviously is regional, Inland Empire Health Plan obviously regional, but Brand New Day and particularly Blue Shield of California are statewide.
Awesome. Thank you again so much. Any other member questions for Dr. Chen? Okay, we really appreciate it, and hopefully you'll come back and show us more whenever we have any updates. So thank you and really appreciate it.
Thank you, President O. Really an honor to be able to speak to you all. And President O, just so you know, that is a Korean flag behind me. My wife is Korean. I'm not Korean.
Oh, yeah. Thank you. Thank you.
Thank you.
Yay.
Have a good day, everybody.
President O, if you wouldn't mind opening up for public comment.
Oh, yes, go ahead. So since we're a public agency, we also provide the members of the public an opportunity to provide comments. So if you can provide some additional information if members of the public have any questions.
Sure.
So the board accepts public comment on the matter under discussion. So moderator, if you could open up the public discussion for Dr. Chen.
Thank you, Mr. Board President. I have opened up the Q&A panel, and if any member of the public would like to make a comment on this agenda item, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists. We are displaying instructions for your reference, and we do have some requests for comment already. The first is from Danny Martinez. So Danny, I will give you permission to unmute yourself. All right, Danny, you should be able to unmute yourself, and you will have 2 minutes. There you go. And you're unmuted.
Thank you. Danny Martinez with the California Pharmacists Association. Good morning, board members. Good morning, Dr. Chen. Fantastic presentation as usual. I've seen this presentation now probably on 3 or 4 different occasions, and it impresses me with this. I do want to say that we are, as an association with CPHA, extremely proud to work with Dr. Chen on all of these initiatives. You know, for those of you on the board who might remember, CPHA had been trying to get the Department of Healthcare Services to cover MTM, CMM, whatever version it is, for several years, and to unfortunately with no luck. And to borrow a phrase from Dr. Chen that he just recently used, kind of thanks to COVID, they looked at it and with evidence that Dr. Chen did provide, decided that this was something that they were going to cover for Medi-Cal patients. That is only one section of the population. Obviously, patients are not only in Medi-Cal. We are, again, extremely excited to work with him on these various issues with DHCS, with Cover California. I think kind of the next phase of this, and Dr. Chen, you can agree or disagree or add additional commentary, but you definitely want to work to reach the rest of the health plans in California. Now, in terms of what what the board can help in this endeavor, I don't know if there's any opportunity for the board to speak with either the Department of Managed Healthcare to grab the health plans together, come to some sort of meeting or summit or something to that effect, where Dr. Chen can provide this presentation to all of the plans and see what else could possibly be done to further expand to as executive officer mentioned about
10 seconds.
I think that's kind of what we're looking for at this point. So again, we're really proud to work with Dr. Chen, and looking forward to see if he has any feedback on that.
Yeah, Danny, thanks so much. As you know, I love working with you. Danny was the first to let me know about the MTM benefit that was coming through Medi-Cal, and was right on it and getting us into a conversation with Medi-Cal on it. So I think we couldn't have really achieved any of this without Danny and CPHA support. Yeah, Danny, you hit the nail on the head, right? This is exactly what we need, and I probably should have mentioned that. I said at the end of my comment that getting more plans engaged would be key, but if there is a way that the board can help get us an audience or a chance to share this work with other plans in the state, I agree, that would be fantastic. We're partially getting that through Cover California, at least the participating plans, but certainly not all the plans in the state.
All right, our next request for comment is from Stephen Gray. And Stephen, you should now have the ability to unmute yourself. All right, you're unmuted.
Thank you. Can you hear me okay?
Yes.
Yes.
Yes. Steve, congratulations again. An excellent presentation as always. You did comment on how pharmacies could get involved. You commented in response to the question about how FQHCs can get involved. Are there any plans, or do you already have in place a way for pharmacists who have maybe their own office-based practice and are not involved, under the auspices of a pharmacy or an FQHC, to get involved with this process. And if not, I'd like to suggest perhaps putting together a group working with the AMCP and others to get those health plans all involved and working with pharmacists here in California. Thank you.
Yeah. Steve, thanks so much. Yeah, great suggestion. It's funny because when we developed California Right Meds, we actually didn't think that we would be solely focused on community pharmacy, but because our initial partnerships were with managed care plans that didn't really have their own facilities and were quite widespread, it just kind of made sense. So we've never said it's restricted to pharmacies. We want to welcome and include office-based pharmacists, clinic-based pharmacists as well. We do have some that participate, but certainly not a big focus. And I think that's a great idea, Steve. I think the more we can engage pharmacists that are more in administrative and clinic roles, it'll help this program, because the learnings that you get in those settings are very much adaptable to the community pharmacy settings, right? And vice versa to some extent.
All right, this is a moderator, and I see no further requests for public comment. Mr. Board President, shall I close the Q&A panel?
Yes, please. Thank you, moderator.
You're welcome.
All right. Thank you again, Dr. Chen. We really appreciate your time, and we'll hopefully see you soon.
Thank you very much. Thanks for your time,
right.
everybody.
Thank you. Thank you, everyone. Okay, so now we're moving on to the next agenda, item 15, petitions for reinstatement of licensure, early termination, or other modification of penalty. We are going to turn on our videos for this session. We're going to take a 15-minute break so that we can get everything situated. For everyone who's ready, just stand by. We'll be back in 15 minutes. For petitioners, as well as Judge Aspinwall, anyone also need to test the video, stay on, and we'll do technical check. But we'll be on break for 15 minutes. We'll be back at 10:12. Well, we'll just do 10:15. We'll be back at 10:15. But anyone wanting to do tests, camera test, also all the petitioners, please stand by to check your videos and audios working.
Okay, good morning. This is Judge Aspinwall, just testing to see if I can be heard.
This is a moderator, and yes, we can see and hear you.
Great. Okay. Then I will.
Myself having a challenge, so I'm going to actually get out and get back in. If you could please promote me back when I'm back in. Sorry.
All
okay.
Right.
So I'll mute myself and turn off my video until 10:13.
Sounds great.
Thank you.
And then, you're welcome. And then our district attorney, Christina Jarvis, would you like to check your mic as well?
I would. Can you see and hear me?
Yes. Wonderful. Thank you so much.
All right. Thank you.
Uh-huh.
Is there a way to adjust my background so it's sort of the unfocused, blurry background?
There is. If you go up to the top of your WebEx screen for audio and video, and then one of the lower ones should be change virtual background.
Let's see. I have up
It's
to audio and video up at the top.
exactly up at the very top. Gives you a few
Okay.
different things.
Okay, it says switch audio, WebEx, unmute, video settings.
Yeah, under that.
And then go change virtual or video.
Change virtual background.
Okay.
And then the second one, the first one says none, and the second one is blur.
Got it.
That's what a lot of people use.
Okay, great. Thank you.
You're very welcome.
Oops, doesn't look like that worked, or it didn't hold.
I agree. It doesn't look that way. Let's see if there's a way you need to apply. Oh, and then, so if you hit blur, and then I believe there's an apply button at the bottom of that block of options.
Got it. Okay.
There you go. Now you're blurred. There, your
Okay.
background.
Yeah, thank you.
You're welcome.
Hi, this is a moderator, and Tony Walker, I'm going to give you permission to unmute yourself so we can just do a quick mic check. So you should be able to unmute yourself now. All right, we'll come back to you. All right, this is a moderator, Tony. It looks like you're unmuted. Can you hear us?
Yes, I can. Can you hear me?
Yes, wonderful.
Oh,
So when it
that
comes,
will help.
yes. And when it comes time for your petition, we'll go ahead and promote you. Right now, you're an attendee.
Okay. So shall I mute myself again?
I'll go ahead and do that. And then once it's time for you to be part of the presentation, you'll have the ability to unmute yourself.
Okay, thank you.
Sure.
Trisha, sorry if I missed it since I had to get out. Do we have the other party ready as well?
Thank you, Sun. I do not see the other party.
Oh, okay. And check what's going on with the second party. Sorry, I'm gonna text her.
Yes, I will check it.
Hi, this is the moderator. And while we wait on getting those other petitioners on board, Tony, can you try turning on your camera real fast? You should see a camera next to your microphone icon that you can turn on.
It's not my computer camera. Is that what you're referring to?
So you should see a start video option next to your microphone icon, and that's what turns on your camera if you've got one.
Okay. Start video. Is that what you're saying?
Yep, exactly.
Okay. Yeah, I see my camera's on.
Okay.
I have it covered up right this minute, so when it's my turn, I'll take that cover off.
Okay, that's fine.
Okay.
All right, great. Thank you so much.
Thank you.
Mhm.
One, except Jason and Ricardo, almost there. Okay, while we're waiting for Jason and Ricardo, Judge Aspinwall, do you prefer which one goes first?
This is Ricardo. I'm here.
Oh, hi, Ricardo. Do you have your video, Ricardo, or?
Yeah, just give me a quick second. I'm ending another little quick meeting. I'll be there.
Okay.
I'm here, Song.
Oh, hi, Jason. Do you have your video, Jason?
Yes, just 1 second.
Okay.
And then Song, are we gonna do it in the order that is in the agenda?
Yeah, we could just do that. Let's just do that.
I just wanna make sure I have the right stuff pulled up.
This is Christina Jarvis. If I might recommend that we take the Jurupa Valley Pharmacy first, since they do have an attorney present.
Okay, sounds good. Thank you.
Yeah, that's what's in the agenda. That's what's first.
Just waiting on Ricardo, but and Nicole's is not showing, but we're just gonna get 1, 2, 3, 6. Cannot start yet. Sorry, Judge Wall. We're just
That's okay.
Members, some technical. Oh yeah, Nicole's computer crashed, so it's starting again. Technical difficulties as always. The world of WebEx.
Okay, I'm back on.
Hi, Ricardo.
Hi.
Okay, since we have a quorum, I'm just gonna take attendance really quick. Nicole is restarting. She'll be joining probably in the middle as soon as she can. But we're gonna get started.
President O, if Nicole must be here to hear the whole petition, or she can't participate in the vote.
Oh, okay. Well then, okay, we'll have to wait. Okay. Sorry.
Yeah. I apologize for the interruption. This is Ann. I believe Nicole can hear. She just can't see right now.
Okay. Should we try to have her restart and get back in?
I believe she's in the process of doing so.
Okay. All right. So we can get started then. We don't need to see her. As long as she can hear us.
Yes, and she can hear. She just confirmed it again.
Okay. When we take attendance, how would we confirm? Just via text or something?
Well, she can voice. Choose voice, right?
You're saying she can't mute. She can't unmute.
Oh.
Okay, we'll just roll call.
If it would be okay, I'll run through the roll. I have the names of board members written down, and if I go through them in the order I have them, then it's easier for me to check them off than scanning around looking for a name.
All right, in that case, there's Nicole. All right, I'll take the meeting over to you, Judge. If you could just take a roll call to establish a quorum. Thank you so much.
Okay, so we are on the record before the Board of Pharmacy in the separate matters of petitions for modification and penalty relief. And before we go any further, I would like to check the roll of the board members to ensure that we have a quorum. And I see that Dr. O is present, correct?
Yes, I'm here.
And is Dr. Serpa present?
Here, thank you.
Is Mr. Patel present?
Present.
Ms. Butler? Not present. Mr. De La Paz? Not present. Ms. Kim?
Good morning, Your Honor.
Ms. Kim is present. Mr. Sanchez?
I'm present.
Thank you. Dr. Thibault? Nicole Thibault?
Yes, good morning.
Good morning. Present. Ms. Veal?
Yes, Your Honor, I'm present.
Thank you. And Mr. Wise?
Yes, here, Your Honor.
Thank you. Record should show we have a quorum. So let me go through a few preliminaries. My name is Timothy Aspinwall. I'm an administrative law judge in the Office of Administrative Hearings, and I have been assigned to preside over the petitions today. And may I please have the appearance from the Attorney General's office?
Yes, good morning, Your Honor. Christina Jarvis, Deputy Attorney General.
Thank you. And the petitioners in today's hearings are Ekta Patel with the Associated Pharmacy, Jurupa Valley Pharmacy, and Ms. Patel is present. Is she represented by counsel?
She is, Your Honor. I'm Steve Zeigen, representing both petitioners Patel and the pharmacy.
Okay. And can you spell your name for me? Is it Steve with a V?
Yes,
And is it Stephen?
it is.
And your last name, please?
Z as in zebra, E-I-G-E-N as in Nancy.
Thank you. Stephen Zeigen.
Correct.
Counsel. And so Ms. Patel and Jurupa Valley are present, being represented by Mr. Zeigen. And is Ms. Walker also present?
Yes.
Thank you. And are you represented, Ms. Walker?
No, I am not, Your Honor.
Okay. And let me go back to Mr. Zeigen for a moment. Do you have any witnesses other than your client that you intend to call today, Mr. Zeigen?
No, Your Honor.
Okay. And are there any documents other than those documents which were submitted with the petition packet that you're wanting to introduce into evidence?
Petitioner requested me prior to coming on the video whether the board would be interested in seeing documentation confirming the various efforts she's made to become compliant and remain compliant. It's up to the board whether they want to see them, because the declarations, especially that of Mr. Patterson, clearly indicate that for the last 3+ years she has been so. But if the board requests them, we would be happy to submit them.
Well, I'm not going to advise you how the board or speak for the board. what I will say is that if you do wish to have them considered, you're going to need to get them submitted electronically. They will then need to be distributed to board members, and they will determine how much time they need to consider those, or as a threshold matter, whether they wish to entertain additional documents in the first instance. So I hear what your question is, but I think that's a determination that you will need to make in terms of whether you wish to make that request.
Petitioner, Your Honor, has handed me several pages of prescriptions which show the various precautions via red flags that she has undertaken. I will advise the office to go ahead and electronically submit them to the board, and they can determine how they want to handle it once it's received. Is that acceptable?
As a matter of procedure, it's going to need to be circulated to the board members for them to consider today. I have seen that done, but I don't know if there is anyone here who wishes to speak to that logistical issue.
Your Honor, if I might, I've advised client, I don't believe they're necessary given all the evidence we've submitted. We don't want to do anything to the board or with the board that might delay their decision-making process. So I'll withdraw our request.
Okay, then the request is withdrawn, and the only documents you have for the board are those which have already been submitted for consideration.
Thank you.
With the petition packet. And Ms. Walker, the same question I have of you, do you have any witnesses other than yourself who you wish to have testify today?
No.
And do you have any documents other than those which were included in the petition packet that you wish for the board to consider?
No, I do not, Your Honor.
Thank you. Okay. The other thing that I would like to advise the parties, in particular Ms. Walker, given that she represents herself, is that the proceedings today concern your rehabilitation since the prior discipline was imposed. The focus of the board is on your rehabilitation since that time, which is to say this is not an opportunity to go back and try and relitigate the case in any fashion. In terms of procedure, the Deputy Attorney General, Ms. Jarvis, will first introduce the case and provide a summary to the board, which I will then mark and admit into evidence. After that, you'll have an opportunity to testify under oath, and I will swear you in. You will say what you have to say. The board members and Ms. Jarvis may ask you follow-up questions. And then after that, you will have an opportunity to make any closing remarks that you may wish to make. The board will then go into executive session and deliberate about what should be done. And once they make a decision, I will prepare a written decision that reflects the board's choices and have that done within 30 days. So you will not be getting a decision today. It will come in the form of a written decision after the board has deliberated and after I've had a chance to prepare that decision. So those are the preliminaries that I have. And at this point, I'll ask the president of the board if we are ready to proceed with the Ms. Patel and Jarupa Family Pharmacy?
Yes, Your Honor, we're ready.
Thank you. Okay, then. We are on the record before the Board of Pharmacy in case number 6230. This is the matter of Jarupa Valley Pharmacy and Ekta Patel. And the record should reflect that a quorum is present and that Ms. Patel is represented by Stephen Zeigen. At this point, Ms. Jarvis, would you like to introduce the case?
Yes, thank you, Your Honor. And good morning again. I am Deputy Attorney General Christina Jarvis, and I am appearing here on behalf of the Attorney General for the people of the state of California. My role is not necessarily adversarial, but it is intended to protect the public interest. This matter arose through the filing of an accusation, after which petitioners proceeded to an administrative hearing. After the hearing, a proposed decision was issued, which was adopted by the board, effective on December 19th, 2018. Both of petitioners' licenses were revoked, with the revocation stayed for a 4-year probation period with specified terms and conditions of probation. Petitioner Patel is the owner and the pharmacist in charge of Jarupa Valley Pharmacy. And therefore, when I speak of actions taken either by petitioner, the actions can be assumed to be taken by petitioner Patel on behalf of the pharmacy or by other employees of the pharmacy on behalf of the pharmacy as supervised and approved by petitioner Patel. The underlying facts of the matter are that on January 10th, 2017, a board inspector conducted an inspection of the pharmacy, assisted by petitioner Patel. Petitioner Patel was unable to locate a current biennial inventory. The last had been completed in January of 2014, so 3 years previously. And then additionally, approximately 91 prescriptions on 38 prescription documents had been filled that lacked the required, quote, California Security Prescription watermark, among other flaws. Additionally, 525 controlled substance prescriptions had been dispensed that contained significant irregularities and red flags such as those identified in the Pacifica Pharmacy presidential decision. Particularly flagrant were multiple misspellings of codeine as codin, C-O-D-I-N, or C-O-D-I-N-E. Additionally, these prescriptions, which was for Phenergan with codeine, were for a cough syrup with these misspellings, yet the prescription stated that they were prescribed for low back pain, which is not medically indicated. Ultimately, there were 4 causes for discipline proven at hearing. Unprofessional conduct for failing to comply with the biennial inventory, filling controlled substances written on non-compliant prescription forms, dispensing prescriptions with a significant irregularity, uncertainty, or ambiguity, and failing to comply with the requisite corresponding responsibility. In mitigation, the ALJ at the time, administrative law judge, noted that petitioner had taken ownership of these issues, had engaged in extensive remedial action, appeared genuinely remorseful, and undertook a robust re-education plan for herself. Now, at this time, petitioners are 100% compliant with their probation terms, including repayment of $10,000 in investigation and prosecution costs. That was ordered as $5,000 to the pharmacy and $5,000 to petitioner, but it has been paid in full. Petitioners have also completed enough time, nearly 3 years, on probation to be eligible to bring this petition before the board. In support of her petition, petitioner has provided continuing ed certificates totaling 33 hours from October of 2019 through June of 2021. Petitioner also provided 8 letters of recommendation, all of which were able to be verified by board staff. Now, 3 of those letters are by employees, 2 pharmacy technicians and 1 pharmacist, and 1 was by petitioner's pharmacy consultant. But those letters I'm highlighting here because it is interesting to note that they all address how Petitioner Patel emphasizes being aware of red flags and being aware of the corresponding responsibility for each technician and each pharmacist. Now, the letter writers all state that they are aware that Petitioner is on probation, that Petitioner has a passion for her patients and her profession, that she is thorough and professional. She takes every measure to ensure the validity of controlled substance prescriptions. And then one author is also an office manager for a physician whose patients fill their prescriptions at the pharmacy, and states that Petitioner has assisted in educating her and guiding their office in ensuring that they are prescribing properly and for valid reasons. At this time, I would like to identify the Exhibit 1 as consisting of all the documents I've just identified as the petition packet, along with the notice of hearing, the acceptance of electronic recording, and the memorandum to the board.
Okay, Exhibit 1 is so marked and admitted in evidence. I have one question about that I will bring up now, and Ms. Jarvis, you might address it, or that might be something for Ms. Patel to address. I notice on the petition itself, I'm sorry I don't have page numbers, but it's the first petition in the packet, and it is for California. It's for Jurupa Valley Pharmacy, and it gives the license number is PHY 57522, which does not match the PHY number on the disciplinary decision and order, which is 51190. And so I don't know if there's a reason for that difference or if that was a mistake. Do you have any insight, Ms. Jarvis?
I do, Your Honor. And if I can direct you to Exhibit 2, which is the decision and order in this matter. The first page of Exhibit 2, actually the first 2 pages, is a stipulation for continuing jurisdiction. And it appears that the Jurupa Valley Pharmacy moved and therefore is required to obtain a new license. And so in October of 2019, they entered into a stipulation for continuing jurisdiction for the new license at the new address on the same terms as set forth in the decision and order. So because of the way the Board of Pharmacy licenses their pharmacies, when a change of location occurs, then the entire license is anew. It is not renewed. It has to be a completely new license because it's a new location. And so that's why it's a different license number now, but it's the same business, it's the same petitioner as it's set forth in the decision and order.
Okay, thank you for that clarification. I appreciate it. And are you offering Exhibit 2 in evidence as well?
I am, Your Honor. So Exhibit 2 consists of that stipulation for continuing jurisdiction, and then the final decision and order in Board of Pharmacy disciplinary case number 6230.
Okay. Exhibit 2 is marked and admitted in evidence.
Thank you, Your Honor. Then at this time, it is now the petitioner's opportunity to address the board. Thank you.
Thank you. Okay, Mr. Zeigen, do you wish to make any preliminary remarks before Ms. Patel has an opportunity to testify?
I do, Your Honor, with permission.
Yes.
Okay. Good morning, panel members. This morning you will hear the petitions for early termination of both Ekta Patel personally and on behalf of her pharmacy, Jurupa Valley Pharmacy, of which she's the owner and pharmacist in charge. As the panel is aware, Ms. Patel bears the burden of establishing sufficient rehabilitation by clear and convincing evidence in order to warrant the early termination of probation. Pursuant to Section 4309 of the Business and Profession Code, The board may consider, among other factors, Ms. Patel's activities since discipline was imposed, the nature of the underlying offense, and the various documented rehabilitative efforts undertaken by Ms. Patel. The facts in this matter show that on January 29, 2010, Ms. Patel was issued pharmacy license 636609 and later received pharmacy permits 57522 and then 51190 with respect to the Jurupa Valley Pharmacy. On November 7, 2017, an accusation was filed against petitioner, which alleged the various causes and for discipline that were enumerated by Ms. Jarvis. I don't need to go through them again. I submit, panel members, that the decision authored by Administrative Law Judge Adam Berg following the September 11 and 12, 2018 hearing is indeed very instructive in regards to determining whether to grant this petition. And which, given the time of the hearing, it's clearly been more than 3 years with regards to the undertakings by Ms. Patel in response to the allegations of the accusation. I would direct the panel's attention to pages 17 and 18 of Judge Berg's decision, wherein he opined Ms. Patel's testimony was sincere, genuinely remorseful, that she had fully cooperated with the board's investigation, and that more than 3 years ago, Ms. Patel had already undertaken steps to prevent a recurrence of the events alleged in the accusation. Paragraph 32 of the decision details many of the improvements petitioner made back in 2018 with respect to the dispensing of controlled substances. 1, she refused to accept any prescription for a customer outside a radius of 5 miles from the pharmacy. 2, she refused to accept cash for controlled substance prescriptions. 3, she refused and still refuses, and she'll explain why, to stock oxycodone and promethazine in her pharmacy. 4, she posted red flag indicators for her and her employees to determine possible problematic indications with the prescriptions, which ultimately led to her refusing a number of those. 5, she made customers with controlled substance prescriptions wait for 1 hour to ensure the pharmacy had time to go through those various procedures. These protections and more, panel members, are what led Administrative Law Judge Berg to impose 4-year probation rather than the more stringent disciplines such as revocation. And of course, the adoption of the decision by this panel indicated an approval and acceptance of Judge Berg's rationale. Panel members, what was true 3 years ago continues to be true today, as attested to by petitioner's restating of the policies she implemented and has continued to employ to ensure there is no recurrence of what transpired previously. Paragraphs 17 and 19 of the respective petitions address those policies petitioner has implemented to ensure the safety and accuracy in the dispensing of controlled substance prescriptions. Our petitions contain letters of support from 8 individuals: pharmacists, customers, an office manager for a physician, and a pharmacy board consultant. I would ask the panel to pay particular attention to 2 such letters. First, the letter of support by Rod Patterson, who has been conducting quarterly visits of the pharmacy on behalf of the board. Mr. Patterson testified at the 2018 hearing about petitioners' efforts to implement safety procedures in conformity with the standard of care to assure the legitimacy of the controlled substance prescriptions. At that time, more than 3 years ago, he testified petition's efforts exceeded the standard of care. In his June 2021 declaration, he reiterated the continuation of those safety policies and strongly encourage this board to consider the petition's request for early termination. Similarly, the declaration of Lorena Magdaleno, the office manager for Dr. Nguyen, Nguyn, noted that through petitioner's educational efforts with Dr. Nguyen, he had improved his ability to write properly documented, appropriately indicated controlled substance prescriptions. Petitioner had indeed referenced this physician at the hearing as well. Panel members, we submit both petitioner's petition and that of her pharmacy have met the burden of establishing by clear and convincing evidence their respective probations should be terminated early. Petitioner took her responsibility to ensure the safety and legitimacy of the controlled substances dispensed by her pharmacy very seriously from the outset and has continued to do so today, even at the expense of costing her pharmacy customers and business by refusing, as noted by Mr. Patterson in his most recent declaration, to carry oxycodone and promethazine. Accordingly, panel members, after you've had a chance to question Ms. Patel and have heard from her with regards to her sincerity, her genuine remorse, and her continued efforts, we believe that both petitions for early termination should be granted. Thank you.
Okay, thank you, Mr. Zeigen. And at this point, I'm going to ask Ms. Patel, if you'll raise your right hand, I'll swear you in. Do you solemnly swear the testimony you're about to give shall be the truth, the whole truth, and nothing but the truth?
Yes, I do.
Okay, and you're going to need to speak up just a bit. Mr. Zeigen, do you wish to question Ms. Patel, or are you asking that she give a narrative?
Would you be more comfortable? Okay, Your Honor, I did prepare some questions for Ms. Patel in anticipation of the questions that Ms. Jarvis might ask. So with your permission, I will ask a couple of those, and whatever additional questions the board or Ms. Jarvis may have prior to Ms. Patel's own personal statement, by all means, they can ask them.
Okay, well, let me just point out that in this proceeding, I'm not going to sustain any objection to a narrative testimony or a response that is a narrative. So, so please go ahead.
I understand, Your Honor. Thank you. For purposes of background, Ms. Patel, when did you graduate from pharmacy school and receive your license?
Received my license in January of 2010.
And where did you graduate pharmacy school?
Graduated in the year of 2000 from India.
Okay. And would you please tell
Ms. Patel, we can barely hear you, so if you can scoot closer to the microphone.
That's the microphone.
Yeah. Okay. Okay. What is your employment history?
After getting licensed in California, I had been hired as a pharmacist at CVS Pharmacy and eventually moved to Rite Aid Pharmacy as a pharmacist in charge and worked there for 2 years.
And when did you first open Jurupa Valley Pharmacy?
2013.
Okay. Now, we all heard the allegations and the accusation as laid out by Ms. Jarvis. Would you please tell the panel members in your own words, and it can be a narrative, those safety measures that you've undertaken to make sure that all controlled substance prescriptions are appropriately dispensed?
Okay. Firstly, I have implemented strict policies and procedures in scrutinizing all prescriptions for controlled substance be written on DOJ compliant prescription pads, and encourage doctors to prescribe all controlled substance prescriptions electronically because it reduces opportunities for theft and illegal misuse of paper prescription forms and aids in providing timely patient care. And also have red flags listed in the pharmacy to make sure that we don't miss any red flags, whether it's me or my technician.
Now, have you continued not to stock oxycodone and promethazine?
Yes.
Would you please tell the panel members why?
Because I found in the last few years of my pharmacy practice and my personal opinion that those were the two drugs that were of interest when it came to either drug diversion, theft, or even presenting illegal prescriptions into the pharmacy. So I thought that it was in the best interest to just kind of put a stop on that.
Okay. Now, assume that you have a patient with documented pain, such as a cancer patient, who needs pain medication. How do you handle those prescriptions?
Well, firstly, I either try to ask the doctor to change the strength if the patient is in a real need or an urgent need, because we don't carry a particular strength. We do carry other strengths of oxycodone. We just don't carry a 30 milligram strength, because that is something I found was a drug of interest. And if still the doctor doesn't agree, then we would refer the patient to the nearest pharmacy where they can get.
Now, you have maintained a strict geographical limitation regarding the customers at River Valley Pharmacy, correct?
Right.
What is that radius?
5 mile radius.
And why did you elect to do that?
Just to really, during the investigation, the inspector had really brought in to my attention that when the patients are traveling from a great distance, that's something that a pharmacist should view as a red flag, which until then, I didn't think of it like that, but then we just decided to implement that regulation, and since then we've just followed that.
Now I'm going to ask a follow-up question. Let's assume today that the board grants the petitions for early termination and probation's terminated, both for you and the pharmacy. Would you modify that particular geographical limitation, or how would you handle that with regards to your business?
I would modify it to an extent of maybe 20 mile radius, because it has really affected the growth of business. 5 mile radius is a very small radius to stick to. And I feel like I would open geographical radius, but not anywhere beyond 25 mile radius.
Okay. Now, how has being on probation, well, let me ask you this. Has being on probation negatively impacted you and or your business?
Well, firstly, of course, I love being a pharmacist. That's who I am. It's the part of my identity. I took a lot of pride in my profession. When I was given the probation and having to post the probation notice in the public view, that affected my image within the community. And it also restricted me from welcoming new patients because they didn't feel confident in what we did. But with the help of today's meeting, I'm hoping that will change.
Well, you mentioned something to me prior to the meeting. Has being on probation also impacted your ability to deal with vendors?
Yes. So we weren't able to get any new contracts with the vendors, neither than any PBMs. It also affected me getting newer contracts with to extend my pharmacy services with government agencies. Like, for example, with the COVID, we wanted to provide a rapid testing, but I was denied by the Department of Healthcare Services, and I wasn't able to do that for the community just because of the probation.
And of course, as long as you stay on probation, you have probation monitoring costs, correct?
That is correct,
And
quarterly.
Okay. Okay, that's all the questions I have, Your Honor.
Okay. Ms. Jarvis, do you have any questions of Ms. Patel?
Just one, actually, Your Honor. Petitioner Patel, you mentioned that should you be released from probation, you would probably expand to a 25-mile radius for your patients. What made you choose 25 miles as a radius?
When we came up with the 5-mile radius, I didn't realize how restrictive that was going to be. And I had to continuously keep denying a lot of new patients, even though patients from my area were moving out of the 5-mile radius. Anything beyond 25 mile radius is just unlikely for any patient to travel that great of a distance, considering how many pharmacies there are right now. So to me, that would still be something that wouldn't make any sense for a patient to travel beyond 25-mile radius to come to my pharmacy.
And it looks like,
yeah.
okay, it looks like although your address is Jurupa Valley, that's essentially part of Riverside. Is that correct?
Yeah, it's a smaller town right by Riverside. It's called Jurupa Valley.
Okay. And how do you determine that radius when you receive prescriptions?
Just through Google Maps. I mean, I'm very familiar. I've been there for the last 7 years. I'm pretty familiar when people are beyond 5-mile radius, but if it's still in doubt, I can use Google Maps to make sure that we're not. If somebody came from, say, for example, Corona or Pomona, then that would be an indication that it's way beyond 5-mile radius.
Do you do that every time you fill a prescription or just the first time you receive a prescription for a specific patient?
That's correct. Anytime we get a new patient, that would indicate me to make sure that we are not filling for them that are beyond 5-mile radius.
Thank you. I have no other questions at this time, Your Honor.
Okay, at this point, the board members have an opportunity to ask questions, and I'll start with Dr. O. Do you have any questions of Ms. Patel?
Thank you, Your Honor. I actually do not have any questions at this point. Thank you.
Ms. Serpa, do you have any questions of Ms. Patel?
Yes, just a couple. Thank you. Ms. Patel, I wanted to thank you for coming to the board and making your presentation, and was very impressed by your number of letters from colleagues, licensees in the multiple qualifications for letters. Many of them stated your advocacy regarding controlled substance safety, and I just wanted to thank you for that. Can you speak a little bit to how you have impacted the community in these last 3 years?
Well, firstly, are we talking about in regards to the controlled substance prescriptions, or?
Yes.
Yeah. Well, just understanding the corresponding responsibility that a pharmacist has in making sure, firstly, that the prescriptions are prescribed on blind pad, and that the drug diversion prescriptions are not stolen. Prescriptions have been written for the legitimate medical purposes. They reflect the correct diagnosis codes. And just that a pharmacist, apart from just the doctors doing the right thing for the patient, that a pharmacist does have a responsibility in ensuring that the drugs end up in the right hands, and that the public safety is my responsibility.
Thank you. That's all, Judge.
Thank you. Mr. Patel, do you have any questions?
I do not have any questions. Thank you.
Ms. Kim?
No questions, Your Honor.
Mr. Sanchez?
Yeah, no questions.
Dr. Thibault?
No questions, Your Honor. Thank you.
Ms. Veal?
Yes, Judge, I just have one or two. First of all, thank you, Ms. Patel, for coming before us today. It's always good to hear and see from the petitioner. My number one question is, your consultant, Mr. Patterson, do you know when he is coming in to visit your pharmacy, when he makes his quarterly visits?
No, I mean, we know it's quarterly. However, the dates are pretty much, they could walk in at any time. Same thing with the BOP inspector. It's quarterly, but there's not really assigned date and time when they can walk in. They can walk in at any time.
And do you have other pharmacists that work at your pharmacy?
Very rarely. When I have a day off or a doctor's appointment, then they do.
Okay. And then just one last question about the miles. So you arrived at the 5 miles as you were being put on probation. Is there is there a reason you picked 5 miles?
There wasn't any specific reasons. We just wanted to restrict that just so that it doesn't come from a doctor that is unknown to us. Because one of the red flags was also that if you don't know the doctor, then that's your due diligence. Apparently, there were some incidences where there was no office present. And then how do we know about, oh, this is not an office, it's somebody's house that the prescription's been generated from. So there were a lot of gray areas that I was unaware of. By sticking to 5 mile radius, it really brings into light only the doctors that I am familiar with. I'm going to get prescriptions from those offices. So there would be not a lot of, yeah.
I'm sorry, I didn't mean to interrupt you.
No, that's okay. So there was also going to just cut out a lot of questions that we would normally have on days and times that the doctor's offices are not reachable.
Okay. And so is the 5 mile radius, is that applied to your patients or to the prescriber or to both?
It's to both.
And so if you have a patient that's 5.5 miles and they take a bunch of maintenance medications, but they come in with a prescription for Xanax, do you say no to them today?
Rather than just focusing on strictly 5 miles, it's really the severity of the prescriptions that I'm being presented with. I mean, we can talk about red flags and strict radiuses, but I really have learned to look into the severity of the red flags or the severity of the prescription that I'm being presented on. To that question, I would say no, because if it was written for a legitimate medical purpose, I know the patient and the doctor. 5.5 mile radius is not something it's going to put a stop on it.
Thank you very much for your answers.
Mr. Wise.
Hi, Ms. Patel. I just want to say thank you for appearing today and the changes you have made in your operations to ensure public safety. No questions, Your Honor.
Okay. And Ms. Jarvis, do you have any follow-up questions?
I do not, Your Honor. Thank you.
And Mr. Zeigen, do you have any follow-up questions?
Actually, Your Honor, I do, and I believe it was Ms. Gill who asked the question. I'd like to ask Ms. Patel. Assume panel members now that Ms. Patel is off probation and she's established a 20-mile radius. I'm going to ask Ms. Patel, if you don't know the doctor and you don't know the patient, what protections would you take to ensure the legitimacy of the prescription?
Well, firstly, making sure that it has a unique serial number, which is the new regulation, alphanumeric serial number with the barcode. All the requirements of a controlled substance prescriptions are present on the prescription. Verbally call the doctor's office by making sure that the phone number comes from Google and not the prescription pad. And then just making sure that patient's ID are kept on file. That is again not something we practiced before, but we now do. And just really getting to know the doctor, making sure the diagnosis codes are present, that the symptoms that are presented by the patient does match the diagnosis code on the prescription, and just making sure that it's written for the legitimate medical purpose.
So is it safe to say for the panel members that were the geographical radius to increase, no matter what the mileage you choose, it would be your custom and practice to get familiar with the prescribing physician?
That is correct.
Okay, nothing further, Your Honor.
Ms. Jarvis, any follow-up?
No, thank you.
Do any of the board members have any follow-up questions to the most recent, any follow-up questions at all? And if you do, just speak up. Hearing none, Mr. Zeigen, do you wish to make any closing remarks?
Well, Your Honor, I believe I said my closing in my opening. I truly believe that we have established beyond any doubt the clear and convincing evidence of Ms. Patel's rehabilitative efforts, her sincerity in that regard, her willingness and desire to maintain those precautions. And with that, I would like to give whatever time was remaining for Ms. Patel to tell the panel her particular position.
Ms. Patel, please.
Yes, I hereby request the board to grant me the early termination of probation because it will help me clear my image within the community, help me gain the confidence to welcome new patients, and open the doors for business growth by contracting with new vendors, PBMs, and government agencies to expand my pharmacy services. Thank you.
Thank you. And Ms. Jarvis, do you have any comments that you would like to make before we close?
Not particularly, Your Honor. I have no recommendation for the board to consider, but I see no public safety issues with granting this petition. Thank you.
Thank you. Okay, that concludes the petition hearing in this matter. The record is closed and the matter is submitted.
Thank you, Your Honor.
Thank you. And Dr. O, are we ready to move on to the next petitioner, or do you wish to take a recess? I'll leave that.
I think we can just move on to the next case, Your Honor, if members are okay.
Okay, then we will do exactly that. Okay, we are still on the record, and a quorum of the board is present, and we are moving on to the matter of the petition for reinstatement filed by Tony Gale Walker. This is Board of Pharmacy case number 5879. Ms. Walker, are you present?
Yes, I am, Your Honor. Can you hear me?
I can hear you clearly. Thank you very much. You'll recall the comments that I made early on, the general comments that this is an opportunity for you to provide any information to the board regarding your rehabilitation and steps you have taken since the discipline was imposed, as distinct from relitigating the underlying action. And so you are representing yourself here today, correct?
Yes, I am, Your Honor.
Okay. And so, and that is your wish, you wish to proceed representing yourself?
Yes, I do, Your Honor.
Very good. Thank you. Well, at this point, then, I will ask the Deputy Attorney General, Ms. Jarvis, to introduce the case.
Thank you, Your Honor, and good morning again. I am Deputy Attorney General Christina Jarvis, and I am appearing here on behalf of the Attorney General for the people of the state of California. My role is not necessarily adversarial, but it is intended to protect the public interest. This matter arose via a petition for interim suspension order, which was granted, suspending operation of the pharmacy until an accusation was filed and heard. An accusation was thereafter filed, and the matter proceeded to another administrative hearing, which resulted in a proposed decision that was adopted by the board and effective August 9th of 2017. Petitioner's license was revoked, as was the pharmacy that she owned and managed and operated all by herself. Petitioner had no employees at that time. Petitioner is here only seeking to have her personal license reinstated. The causes for discipline in the final decision were that petitioner engaged in unprofessional conduct as follows. Petitioner failed to maintain the pharmacy in a clean and orderly condition. The findings of the administrative law judge, or ALJ, were that the pharmacy had piles of trash bags obscuring access to parts of the pharmacy, including a back exit. The bathroom was very dirty, including yellow foam covering the walls under the sink and by the toilet. Pieces of foam and paint were found on the floor. The toilet's water tank had no lid, and an object floated in the water bowl. The sink was dirty and encrusted with gray residue, and the water from the sink was yellow in color when the taps were turned on. The counter of the main pharmacy area was cluttered with prescription documents, many of which were dirty and stained, These documents had no organizational features, and the counter itself was slanted downward in a semi-collapsed state. Insects, including gnats and an apparent cockroach, were observed in the pharmacy, and unidentifiable substances and 2 loose tablets were found on the floor near the inventory shelving. Petitioner was given 1 month after this inspection to clean up the pharmacy. Prior to inspectors returning to the pharmacy, they spoke with petitioner via telephone, and she stated that she was working on it and the pharmacy should be cleaned up shortly. When inspectors returned, the pharmacy appeared to be mostly unchanged, with the exception that additional bugs were observed, along with bug traps, and some, but not all, of the bags of garbage that had been obstructing the back room had been removed. There were still enough bags of garbage present that the back door was still inaccessible. Petitioner also failed to have a current self-assessment, failed to provide or make any arrangements to have interpretive services to patients, failed to comply with requirements for storage of controlled substances, and failed to have a biennial inventory of controlled substances. The ALJ who heard the case found that petitioner provided very little mitigating or rehabilitating evidence, showed a lack of basic competence as a pharmacist, and had little to no interest in retaining her pharmacist license, even stating that she would not work as a pharmacist again, regardless of the outcome of the hearing. Additionally, there were aggravating factors of multiple prior citations. Petitioner was ordered to pay the board $2,080.56 for the costs of investigation and prosecution prior to the issuance of any new or reinstated license. To date, no costs have been paid. With her petition for reinstatement, petitioner submitted continuing education certificates totaling 42.5 hours from April of 2020 through December of 2020. She also submitted 5 letters of recommendation, all of which were verified by board staff. Petitioner also submitted a personal statement on her own behalf. The recommendation letters all state that petitioner is a good and giving person, appears honest and reliable, and is empathetic, helpful, and dependable. At this time, I would like to identify and move Exhibit 1 as all of the documents described above as the petition packet, and including the notice of hearing and the memorandum to the board.
Exhibit 1 is marked and admitted into evidence.
Thank you, Your Honor. And then at this time, I will identify and request that Exhibit 2 be admitted, and that includes the decision and order. There were some minor typographical modifications to the proposed decision. And I would ask that in the entire document, including those minor typographical modifications, be admitted as Exhibit 2.
Exhibit 2 is marked and admitted into evidence.
Thank you, Your Honor. Then at this time, it is the petitioner's opportunity to address the board.
Great. Okay, so Ms. Walker, this is your opportunity to speak directly to the board, and I'm going to ask you to raise your right hand and I'll swear you in. Do you solemnly swear the testimony you're about to give shall be the truth, the whole truth, and nothing but the truth?
I do.
Thank you. Please proceed and tell the board what you wish the board to know.
Okay, board, thank you for this opportunity. In the time that I have been under revocation for the last 4 years, I have taken a different direction. I took the course or enrolled in classes to become a drug and alcohol counselor. And I have tried to serve the community during those 4 years. I've worked with the homeless, not directly on Skid Row. Well, at one point directly on Skid Row, but a little west downtown on West 7th Street. I'm currently working at the Mayfair, where they are housing the homeless under Project Roomkey. So to reflect, it was disrespectful of me to not keep the pharmacy in order. That was an assault to the public and to the patients that I served. But I did try to clean it up I did clean it up after the first hearing. And I sent some pictures and all to the judge, but she said that I was supposed to submit those to the district attorney also. But I failed to do that because I'm not represented by an attorney. But all I can say on my behalf is that I've tried to serve the community. As Ms. Jarvis said, we're not here to necessarily punish me. We're here to serve the community and to serve them correctly, to make sure that things are in order, and that's respect of the community and the people that I served at that time. But I think that's all I have to say. I mainly need to get my license back because I need to work with the state of California with Medi-Cal in the position that I'm trying to get to be a drug and alcohol counselor. But as far as pharmacy, I don't think I'll be going back to that. And that's all I have to say.
Okay. Well, Ms. Jarvis may have some follow-up questions. Ms. Jarvis, do you have any questions of Ms. Walker?
I do. So, Ms. Walker, you do not intend to return to work as a pharmacist ever?
Never. And I'm older anyway. I'm almost 70, so I will not be returning.
And you don't intend to run a pharmacy ever in the future?
Never.
Now, you had mentioned in your petition that you worked for Chrysalis, and that's CHRYSALIS Enterprises.
Yes.
And that through them, you worked at various places.
Yes.
What is Chrysalis and what did you do for them?
Chrysalis mainly employs people that have been incarcerated and people that have trouble getting employment. A lot of them are felonies, etc. But I worked there along with doing my drug and alcohol counseling. I was mainly working, I was mainly working with people accused of DUIs because of the fact that my license was suspended with the Board of Pharmacy, or not suspended, revoked. I could not work with Medi-Cal. And that's where your hardcore addicts are treated. I would need to be able to work with Medi-Cal to work with hardcore addicts. And that's what I really want to do.
So you were working as a drug and alcohol counselor for them?
I'm not a counselor yet. I have just finished my 3,000 hours. That's what I've been doing during the time that I was revoked with the Board of Pharmacy, or that time that I am revoked with the Board of Pharmacy. So I've been working with people accused, mainly young people accused of driving under the influence or driving while intoxicated. And that's what I've been doing for the last 3 or 4 years. I took the curriculum and I also worked with that particular clientele.
Now, in your petition, you also stated that there are no courses, quote, needed or available for your violations, and that you merely needed to operate as a professionally competent human being. You repeated that a few times in response to several questions. So did you take any law and pharmacy courses since your license was revoked?
I took so many courses. I don't want to tell an untruth about that. I think I did. I'm not sure though.
Okay. Did you take any courses in like pharmacy law and ethics?
I believe I did. I would have to look at my paperwork again for that though, because I took quite a few courses and I just don't remember. I'm sorry.
So the continuing education certificates you submitted with your petition, are those the courses that you have taken since your license was revoked?
Yes, they are.
Okay, so we can review those. Now, in your petition, you also were asked to explain fully the cause of the disciplinary action. And your statement was that you had poor housekeeping, including dust, prescriptions piled on the countertop, hole in the ceiling, toilet lacking attention, sink was dirty. So you really focused only on the dirty aspects of the pharmacy, but there were a few other violations as well. Do you recall those?
You stated that I did not have an interpreter.
You did not have interpretive services. You didn't have the posters up or any availability of interpretive services for any of your patients, correct?
Correct.
But you didn't list that in your petition. Did you not think that that violation was significant?
Attorney Jarvis, I guess because my license was revoked and I wasn't continuing to operate, I didn't know if that was something I had needed to address once they closed me, once the pharmacy was closed down. Because I remember now, I haven't been operating in these last 4 years. My license was revoked. And when the judge revoked that license, that ended my career as a pharmacist.
So, and what I'm getting at is you did not list everything. So the petition asked you to explain fully the causes for disciplinary action. And you did not fully explain all of the causes. You really only focused on one cause. Did you only think that that was sort of the most important part and the others were not as significant? Why did you focus in only on the dirty aspects?
To be honest, I don't know.
Do you remember filling out the petition? And I know that it was a while ago.
Yes, I did.
But you don't remember what your state of mind was when you were explaining those disciplinary actions?
No, I guess I was concentrating most on the fact that the pharmacy was not in order.
Did you understand the significance of failing to keep a biennial inventory of your controlled substances?
Yes. Yes, and I believe that after the inspector left, I did take that inventory.
Now, if you were to be reinstated after this petition today, you would likely be reinstated on probation. Do you understand that?
Yes, I do understand that.
Okay. The probation terms also require you to work as a pharmacist for a certain amount of time. Are you aware of that?
No, I'm not.
Have you reviewed the disciplinary guidelines of the board at all?
I guess I should have employed an attorney. I guess oh boy.
Well, Ms. Walker, I'm just asking, what you've done to prepare for this hearing. Did you review the disciplinary guidelines before coming here today?
Yes, I thought because I did have a, what do you call him? He's not an attorney, but he is a, I forgot what they're called.
Somebody in the legal field?
Yes, a
Like
paralegal. Yes.
Okay. And did that person help you fill out this petition?
Yes, he did.
I see. Okay. Before your hearing, back when your license was revoked, did you review the disciplinary guidelines at that time?
I believe I did read over it, but it's been a while.
And when you went to that hearing, when your license was revoked, you represented yourself at that time as well. Is that right?
Yes, I did, attorney.
Now, if, again, you were to be reinstated after this petition hearing and the board were to order it, do you think that you could pass the licensing examination again?
Well, it's been 37 years since I went to school, so I am not sure. I would have to do quite a bit of reviewing, Attorney Jarvis.
Would you be willing to basically study for that and retake that exam?
I don't know. That's a decision I would have to think about. I would have to think about that, Attorney Jarvis.
I don't think I have any other questions at this time. Thank you, Your Honor.
Thank you. Okay, at this point, the board members have an opportunity to ask questions. And so, Dr. O, do you have any questions of Ms. Walker?
Thank you, Your Honor. I don't have any questions at this point.
Ms. Serpa, do you have any questions?
Yes, Your Honor, I just have one question. Dr. Walker, you mentioned that in order to continue with your current position and in the drug and alcohol rehabilitation field, you needed to work with Medi-Cal, and Medi-Cal would not allow you to do that because of your revocation of pharmacy license. I'm a little confused about that, and I'm wondering if that is possible that you could still work in this field without a pharmacist license. What's the holdup there if you're not acting as a pharmacist?
No, what I should have said is if my pharmacist license is in revocation status, and Medi-Cal will not allow you to work under Medi-Cal, various constituents in the neighborhood are under Medi-Cal, and quite a few of them are, because I work in a low-income district. They will not allow you if your license if my pharmacist license is in revocation to work under Medi-Cal.
I see. So you're saying you don't need a pharmacist license, but you just need to have the revocation removed.
Right. If since I have a pharmacist license, I need to not be in revocation style. That's in revocation.
And would the history of the revocation impact you also? Would having a history of revocation impact you also?
I don't quite understand your question.
I don't understand how Medi-Cal works in your current field. So it's not that you need a pharmacist license, it's because you have a revoked license. That is the issue. So my question is, if you have a history of a revoked license, is that an issue also?
I don't know. To be honest, I don't know.
Okay. Well, thank you again for your time, Dr. Walker. That's all my questions, Your Honor.
Mr. Patel, do you have any questions?
I don't have any questions. Thank you, Your Honor.
Ms. Kim?
No questions, Your Honor.
Mr. Sanchez?
Yes, I'd like to say, Dr. Walker, thank you for coming before the board, and I thank you for your effort to help those who are less fortunate. And I know not everybody can afford an attorney, and but I appreciate you talking from the heart and being honest with us. Thank you.
Thank you.
Dr. Thibault?
Yes, thank you so much for coming today and meeting with us. I do not have any questions, but just wanted to say thank you for what you've done in the intervening time, becoming a drug and alcohol counselor and working with the homeless. These are very underserved populations. There's a lot of need, so thank you for that.
Thank you.
Ms. Veal?
Yes, just maybe a couple questions, and I'd like to echo what the other board members said. Dr. Walker, we do appreciate you coming and your honesty, being honest enough to say, oh, I don't know the answer to that, or I haven't thought about that. It's refreshing to have that very upfront honesty. So if we were to reinstate your license, just so you kind of understand maybe where we're coming from, once we would reinstate license, and there might be conditions like Ms. Jarvis said, that we would ask you to take the law exam or perhaps the NAPLEX exam to show that you are competent, because we can't reinstate and just say you only do certain things. So if we reinstate your license, basically, and you'd probably be on probation, like she said also, and probation does require you to practice pharmacy. We're basically giving you the opportunity to do any job. We're not going to follow you around to see if you, in fact, aren't going to be a pharmacist. So I just want you to understand, with reinstatement, we have to be convinced that you're also going to be a competent pharmacist. And so that's why normally we would ask you to, take the law exam and possibly the NAPLEX to make sure that you are competent. But it does sound like, as far as Medi-Cal, it's because you've been disciplined that they, and you have this revocation, that's why they have the mark against you. And so we'll take that in consideration also. But once again, thank you for coming before us, and appreciate your, speaking frankly and honestly.
Thank you.
Mr. Wise, any questions?
No questions, but I do want to thank you, Dr. Walker, for attending today and for the work that you are doing.
Thank you.
Okay. And Ms. Jarvis, do you have any follow-up questions following the board members?
I do, Your Honor. And I don't know, Ms. Walker, if you're going to know the answer to this, but according to a quick search on the Medi-Cal providers list, it states that once your ability to be a Medi-Cal provider is suspended, you can petition for reinstatement through Medi-Cal. Have you tried looking into petitioning Medi-Cal to allow you to be reinstated through them?
No, I have not. And that's something that I will do. Thank you for that information.
And then just for the information of the board, I reviewed Welfare and Institutions Code section 14043.6, which states that the department shall automatically suspend as a provider in any Medi-Cal program any individual who has a license or other approval to provide health care, which is revoked or suspended by any state's licensing, certification, or approval authority, or has otherwise lost or surrendered that license. That suspension shall be effective on the date that the license, certificate, or approval was revoked, lost, or surrendered. So it does not say if Ms. Walker gets her license back, if that would still affect her, but that is why she is affected by this revocation. So unfortunately, I don't know the answer about whether or not, if she did get her license back, if it would continue to affect her. I think she would have to petition Medi-Cal to be reapproved. And that is all that I have, Your Honor. Thank you.
Okay, then. Ms. Walker, are there any closing comments that you wish to make before we conclude this matter?
No, I don't have any further comments, Your Honor.
Okay. And is there any board member who wishes to ask a question at this point? And I'll just wait for you to speak up. Okay. Hearing none, that concludes the petition hearing in this matter. The record is closed and the case is submitted. Thank you, Ms. Walker. And you will have a written decision from us no sooner than 30 days.
Thank you, Your Honor.
All right. And Dr. O, I turn the meeting over to you at this point.
Thank you, Your Honor. Okay, so as we're going to move on to closed session, as indicated on the agenda, the board will now move into closed session for the stated purposes indicated on the agenda. Due to technological limitations, adjournment for the day will not be broadcast. Adjournment for the day will immediately follow closed session, and there will be no other items of business discussed. Members of the public, on behalf of the board, I would like to thank you for joining the meeting today. Members, we will begin closed session in 10 minutes. Thank you all. See you all.
And thank you all for your time and attention today. I appreciate it.
Thank you, Ms. Jarvis.
Thank you.